Very good evening, guys. So this session I'll be completely speaking about all your doubts. Whatever your doubts you put forward, I'll be answering to those doubts. So welcome to the platform of eGurukul. I am Dr. Ramyasri. I'm here to solve all your doubts pertaining to obstetrics and gynecology. So starting with, I'll start with some of the doubts which I already got. So So can I see your doubts? Like, once you keep starting asking me your doubts, I'll start answering for it. So I recently had a student asking me about a fibroid. Even if it is an asymptomatic fibroid, you need to remove the asymptomatic fibroid if she has come to you with infertility. Infertility is the symptom there. So when you have infertility and fibroid, you remove it. Okay. Right. Good evening. So I'm waiting for your doubts to pop in so that I can start answering for it. Okay, MTP extended week. So in MTP, actually it is MTP bill now. Earlier it was MTP Act. Now it is MTP bill which is passed, but it didn't become Act yet. So MTP bill may they have changed the you can terminate up to 24 weeks, and you can terminate up to 24 weeks if they have come to you with the incest or rape, or if they have come to you with anomalous fetus, or when it endangers the life of the mother. So you can terminate up to 24 weeks, but that is according to the bill, not according to the it has not yet become the act. Okay. Right. So I have a question from Shefali for our 28th question. So 28th question was about vulval cancer. So it was lateral. It was 3 centimeters lateral to the anus. It was lateral to the anus. As it is not coming in the midline of 2 centimeters, and they clearly told it is lateral, so that is the reason why we are going for ipsilateral lymphadenectomy. As it is 3 centimeters, so it is stage 1B. For stage 1B, if you have lateral lesion, and they mentioned it was lateral to anus. So as it is lateral to anus, you are going for ipsilateral lymphadenectomy. If you had near the anus or to the clitoris or the posterior fourchette or the labia minora, then it would have come in the midline lesion. In midline lesions for 1B, you will do bilateral lymphadenectomy. So this is about the vulval carcinoma question. Okay. Next. So I hope you all enjoyed the questions of the TND. So what is the analgesics which can be safely used in pregnancy when it is not due to pregnancy related? So provided if the patient has come to you in second trimester, we give it tramadol. Tramadol is very safe to use. Second or third trimester, we prefer giving tramadol. Okay, and especially it helps you for treating the pregnancy related as well as non-pregnancy related. All pains decrease. Fixative for pap smear is 95% ethyl alcohol. Ether, earlier we used to add ether also, but now we are not adding ether. We are just giving 95% ethyl alcohol. Okay. And fixative for LBC. Fixative for LBC, liquid based cytology. Fixative for liquid based cytology is methanol. Pritchard regimen and McAfee regimen, both are different. So Pritchard regimen is used in the what do you say, eclampsia, whereas McAfee regimen is the expectant management for placenta previa. McAfee regimen is the expectant management for placenta previa. Okay, and you also have something called Pritchard rule. Pritchard rule is used for abruption, where what we do, the source of these questions is Gynec TND conducted by eGurukul. So it's the TND conducted by eGurukul. It's a doubt solving session for the TND of eGurukul. As well, you can also ask any other questions also. So Pritchard rule is for abruption, where we do immediate termination. Urine output should be more than 30 ml per hour. Hematocrit should be maintained more than 30%. HPV vaccine update. So the now HPV vaccine which we use is the Gardasil 9. The HPV vaccine which we use nowadays is Gardasil 9, which is against the HPV 6, 11, 16, 18, 31, 33, 45, 52, 58. So you give 3 doses, 0.5 ml IM. The targeted age group which you have to give is, we give up to 9 to 26 years. But if they are missed, if anybody comes beyond 26 years, you can give up to 40 years. That's the update which we have. You can give up to 40 years, but when you are giving beyond 26 years, the efficacy will decrease. When you are giving beyond 26 years, the efficacy will decrease. So you can give it up to 40 years. And this Gardasil 9 can protect against pre-malignant lesions and malignant lesions of anal, vulval, vaginal. Right, Zuspan regimen details. Zuspan regimen is for preeclampsia. In Zuspan regimen, loading dose is 4 grams of 20% magnesium sulfate IV, whereas maintenance dose is 1 to 2 gram per hour IV infusion. Okay, maintenance dose is 1 to 2 gram per hour IV infusion. Right, can I get the next question, guys? Okay, so I have one more question posted to me which I'll answer it here because you're not asking me any more questions. So at 25 years old, primey at 30 weeks gestation came with colorless fluid per vaginum. So that means PROM, preterm PROM. On examination, there is rupture of membrane. What is the management? There is rupture of membrane. What is the management? So indeed, they're just asking you 30 weeks mein what is your management you want to do when you have a PROM. Give tocolysis and 2 doses of steroids and induce labor immediately. The options are give tocolysis and steroids, do C-section at 34 weeks, Give 2 doses of steroids and do C-section immediately. Give tocolysis, steroids and induce labor at 34 weeks. As she came to you at 30 weeks, you have to prolong it till 34 weeks. You have to prolong it till 34 weeks, right? So what we do is we give them tocolysis and we give them steroids and we try to pull it till 34 weeks, and at 34 weeks we'll do induction of labor. At 34 weeks we give induction of labor. Okay, so tocolysis usually stops the labor from 48 hours to 7 days. So if possible, but many times PROM they stop contractions and we pull them like many weeks. So yes, if possible, pull it till 34 weeks, and at 34 weeks there's nothing which is telling us that you have to do cesarean section. So you can just go for vaginal delivery there. So I have a video on the eGurukul itself where I discussed about the recent MTP bill. It's hardly 5 minutes video. So in the recent MTP bill, it's the bill not yet passed. So one doctor up to 20 weeks, 20 to 24 weeks, there it tells you have to take the opinion of 2 doctors. One doctor up to 20 weeks, 20 to 24 weeks, 2 doctors. So I posted the link also to you, Chef Ali, so that you can have a look on the entire video. Right, next I have somebody asking me what is Pseudo Meigs syndrome. When you have Meigs syndrome is fibroma plus right-sided pleural effusion plus ascites. Pseudo Meigs is any other ovarian tumor plus right-sided pleural effusion plus ascites. Apart from fibroma, if any other ovarian tumors are there, then we call it as Pseudo Meigs. Okay. Indications of chorionic villus biopsy. Chorionic villus biopsy is done whenever you have past history of anomalous fetus, chromosomal anomaly, known carrier of chromosomal abnormality, any of the partner, family history of chromosomal abnormality, when you have abnormal analytes, so these are the indications where you go for chorionic villus biopsy. Okay, and you don't use chorionic villus biopsy for structural anomalies. You use chorionic villus biopsy only for the chromosomal abnormality identification. Okay, right, what else? Right, so next I have one more question from somebody asking me this, but I couldn't answer them previously. In a female with previous LSCS, where should be the next incision, next LSCS incision? It should be on the previous scar, new site or adjacent the scar, above the scar, below the scar. See, there is a scarred area, so that will be, if you know that is weakened, so put a next incision on the same scar so that you can strengthen it by this suturing again. So on the same scar, on the previous scar itself, we try to put the again an incision. Okay. Right, and just before LH surge, you always have, just before ovulation, you have both LH and FSH surge. That was also one more question which I had. Okay. Right, you are trying to ask me about the teratogenic drugs. So you actually have categorization of the drugs, and there is a big list of drugs. So medications in pregnancy by FDA approved are mainly your folic acid, iron, calcium, doxylamine, which is mainly given for nausea and vomiting, morning sickness. Okay. Ritodrine is also FDA approved for pregnancy for tocolysis. Steroids, that is injection betamethasone and dexamethasone. So those are all the category A drugs which can be safely given. Mainly your folic acid, iron, calcium, all these are category A drugs which can be safely given to the pregnant female. They are called category A. Okay. And somebody is asking me regarding the Edwards syndrome. What are the levels of? So Edwards syndrome, in quadruple test, everything decreases. That is beta HCG, inhibin A, AFP and unconjugated estriol. Everything decreases in Edwards syndrome. Whereas Downs may high, H for high, I for increase. Both these will increase, but AFP and unconjugated estriol will decrease. Okay. Next, I have a question from, what is the next best step after uterine rupture during labor? So whenever there is a patient with uterine rupture, immediately shift her to OT. So you have to go for exploratory laparotomy plus simultaneous resuscitation. Exploratory laparotomy plus simultaneous resuscitation. Okay, I have a next question regarding the speak about the features of Metropathia hemorrhagica and how to go about a question hinting towards the differential diagnosis. Right. So whenever you have a Metropathia hemorrhagica, what is this Metropathia hemorrhagica first of all? Metropathia hemorrhagica is seen in premenopausal women due to anovulatory cycles. Due to anovulatory cycles. So due to this anovulatory cycles, you have excess growth of endometrium by unopposed estrogen. And this creates a pattern of Swiss cheese appearance. So this gives an appearance of Swiss cheese, this excess growth of the endometrium. So these Metropathia hemorrhagica patients have prolonged amenorrhea, basic picture of anovulatory cycles. That is, they'll have prolonged amenorrhea followed by heavy menstrual bleeding. Followed by heavy menstrual bleeding. Okay. This, so you usually see just before we stop our menstruation, the last 3 months we tend to have this irregular cycles because of the anovulatory cycles. For this Metropathia hemorrhagica, the differential diagnosis is endometrial hyperplasias and endometrial cancers. So how do I find out whether it is a Metropathia or whether it is a hyperplasia or cancer? It is by TVS. So on TVS, if you have thickened endometrium, please go for endometrial biopsy. The first line of investigation is TVS, whereas investigation of choice is office endometrial biopsy. Office endometrial biopsy. I hope that clears your doubt, SG. That's about the Metropathia. Next, let's go to the next question. That is, I have a question from Shefali. That is, ma'am, in ectopic pregnancy during medical management, should the female be hemodynamically stable or unstable? She should be stable. Obviously, she should be stable. Medical management, if you're doing, she should be stable. And please, if you're using my last year notes, the management of ectopic pregnancy has been changed. The management of ectopic pregnancy has been changed. So I think that is very important that I briefly tell, even if one student doesn't know the recent advance, we are at loss. So I will tell you the quickly and probably I better make one video so that everyone won't miss it. So according to the recent advance, for medical, we have three modalities of management: expectant, medical and surgical, right? For expectant and medical, few are same. They should come for follow-up. Patient should be able to come for follow-up. Patient should be stable, hemodynamically stable, pain-free and pain-free. That's same here also. Size of the sac. Size of the gestational sac should be less than 3.5 and there should be no FHR, both for medical and expectant management. For doing medical management, for doing expectant management, that is just wait and watch, beta HCG should be less than 1000. Whereas for doing medical management, beta HCG should be less than 1500 international units per liter. Now, when do we do surgical management? Patient not willing to come for follow-up. Not willing for follow-up. Patient is having significant pain. Patient hemodynamically unstable. Sac size more than 3.5 centimeters. Positive FHR. Matlab all that what I have written there ulta. And beta HCG level more than 5000. So beta HCG between 1500 to 5000. You can either do medical or surgical. You can either do medical or surgical. Okay. Can adnexal mass and broad ligament be differentiated on examination? Difficult. But can uterine mass and adnexal mass can be differentiated? Because broad ligament is also adnexal mass. So it's very difficult to differentiate between broad ligament and adnexal mass. But good question. Ma'am, in one question, the partogram presenting CPD but dilated 6 centimeters, then why are we considering it as an active phase arrest? 0 to 6 is latent phase. Anshvi, you're correct, but partogram may we still take 4 centimeters from 4 centimeters as active phase. See, recent update of Williams tells 0 to 6 as latent and 6 to 10 as active. But partogram and even our medical colleges, we consider 0 to 4 as latent and 4 to 10 as active. Partogram it is still 4 to 10 active. Okay. Right. I think I answered all your queries. So I hope I could give you clarity on all your queries. So I hope you all enjoyed the TND of both OBS and Gynec. Any other further queries also, always feel free to ask any of your queries. So I hope I could go through all the questions of all topics in the TND, and I hope it was helpful to all of you. So all the best guys, keep studying, give your max in this next 2 months. Success is definite. So thank you. I hope I cleared all your doubts, and yes, I don't see any more of your doubts. So thank you guys, all the best. Keep studying.